This lecture is on respiratory system problems having to do with the upper respiratory tract, the nasal cavity, the larynx, the trachea, and so on. So we're starting with the nasal cavity. So the nasal cavity is highly vascularized. That means it has a lot of blood vessels in it. Remember, blood vessels are vascular tissue. So we have a lot of blood vessels in the nasal cavity, and also the nose is in a relatively vulnerable position. It's right there on the front of your face. And these two things then, these make the problem of nosebleeds fairly common. Lots of people get nosebleeds, particularly children. And this then is known officially as epistaxis. And minor nosebleeds then can be treated with pinching. Pretty straightforward, but it's done. Or by packing the external nares. All right. On the other hand, sometimes the bleeding is more severe. And if it is not readily treatable by pinching or packing because it originates elsewhere, then you're going to see some different things to do. So more severe bleeding then originating elsewhere may require packing the posterior portion as well, by way of the internal nares. Okay, so how can you get a nosebleed? Any number of ways. So nosebleeds then can result from impact. Somebody hits you, you run into a wall, things like that. It can also result then from drying. It's why people sometimes wind up getting nosebleeds during cold season when the air is frankly drier in places like this. You can also get it from infections, from allergies, from clotting disorders, and even from hypertension. That is to say, high blood pressure. Basically, you've got a whole lot of pretty exposed vascular tissue. And so you wind up with all of these little blood vessels being dried out because you're breathing dry air a lot of the time. You wind up with allergies in your nasal passages sometimes. You can get infections there pretty frequently. And then, as I said, people with clotting disorders, very often you will see the most obvious symptom of this will be nosebleeds that don't get easily controlled. And high blood pressure as well. Just basically you have these thin-walled blood vessels. High blood pressure can then burst some of those tiny vessels, and you wind up, therefore, with a nosebleed. So that then is it for the nasal cavity for the time being. Now I'm going to go on to larynx disorders. And basically you can get infection or inflammation of the larynx. And this affects the vocal vibrations made by the larynx. And this is the condition known as laryngitis, where basically this inflammation of the larynx makes it hard for the vocal cords to vibrate. So laryngitis is frankly usually not serious, but in children you have a different matter here. Viral or bacterial infection of the epiglottis, then, or upper trachea, can be very dangerous. One way to think about that is this. Whereas your trachea may be a tube about that diameter, on the other hand, a baby's trachea is about as wide as my pinky. So as a result, even a little bit of inflammation in or around a baby's trachea can make for swelling, which will close that tiny air passage, and that can lead to suffocation. So this then is called epiglot, that's an O, epiglotitis. Now you've got something serious on your hand, and acute epiglottitis, unfortunately, that's an E there, acute epiglottitis can develop relatively quickly. So you can go from having a well child to having, a kid with some minor ailment or other, to suddenly having this very serious problem. That can happen relatively quickly. And when this happens, the epiglottis can swell. And close the glottis. Okay, the glottis is the official term for the opening through which air passes to get into the larynx, which is where it goes first, of course, and then the trachea. So it is the opening to your respiratory system. It is the opening, basically, after your pharynx. When your respiratory system becomes separate from your digestive system, that opening then is the glottis. And if you wind up having the glottis swelling shut, then you have asphyxiation. So when you have the glottis swelling shut, I'll write that in here. Causing suffocation. We wish to avoid that. Now I'm going to give you a highly diagrammatic look at things so that you can see kind of what I'm talking about. Strictly a diagram, but it'll kind of get you where you're going, I hope. So here we go. Doing this. Give me a moment here. Remember, this is strictly diagrammatic. Yeah, that'll work. So what did I just draw here? Okay, what you are looking at now are the tubes in your throat. Here's the one at the back. So here you have the esophagus. Okay, so here then is the trachea in the front. This is the mouth, so you can breathe in this way. This now is the nasopharynx. I'm abbreviating pharynx with PX here. The area behind the mouth is, of course, the oropharynx, right? And then this peculiar area in here, this, I'm going to just draw some little lines here so you can kind of see the area I'm talking about here. So that then is the laryngopharynx. And this then is your epiglottis. So as I said, remember this is strictly diagrammatic, but I think it should help out. Here's what's going on. When you swallow the food from the mouth, then you wind up having the epiglottis, which is made out of elastic cartilage. It then folds down, and so as a result, the food or water from the mouth winds up being diverted into the esophagus, which is actually further away. So as I said, you actually have to divert the food and water into the esophagus. The epiglottis then closes the glottis, closes the entryway to the larynx and then the trachea, so that you don't wind up getting food or water down your trachea most of the time. So as I said, that's what happens when you swallow. And leading into this, of course, is what happens when you don't swallow, but you have food or water in your mouth and you simply inhale. Remember, this is elastic cartilage. When you swallow, it gets folded down. But when you're not actively swallowing, it snaps back up into this position. It's made out of elastic tissue. So it gets folded down, but then it snaps back up. So when you are inhaling, that means that you can actually inhale and the air will go like that finally into your trachea. You can breathe through your nose, you can breathe through your mouth. All well and good. But let's suppose you have some food in your mouth and then you inhale. Remember that inhalation creates suction. Basically, you do it by way of a partial vacuum. So you can, if you have food in your mouth, you can wind up vacuuming that food into your trachea, and that can block the larynx or block the trachea. And again, now you have a problem with suffocation. But starting with this bit here, here is the epiglottis. So you can see how close it is then to the opening onto the larynx, to the glottis, and that means that if this thing gets swollen, it can potentially swell shut the glottis, the opening to your respiratory system, particularly in a small child that has a very, very narrow opening. So carrying on with larynx disorders here, we're still talking about them. Edema, which is basically swelling. Of the trachea can also occur just below the larynx. And in children, who again have smaller tracheas and smaller glottises than adults do, this is partial airway. Or I will say this. I'll do it this way. This partial airway obstruction then causes the condition known as croup. But I was also talking about what happens if you wind up inhaling. If you have food in your mouth and then you inhale and you vacuum that food into your trachea, what's going to happen then? Remember, the trachea is held open. The esophagus is not. If you inhale, whatever you inhale is going to wind up in your trachea or in your larynx. If you have ever inhaled cracker crumbs, you know what that's like. So let's just keep that picture on the other side of the board there and talk about tracheal blockage. Okay, so most foreign objects that get lodged in the trachea or larynx can be expelled by coughing. We do this a lot. You wind up with something somewhere in here near the top. People cough. People try to get rid of it. They usually succeed. But suppose you're in a restaurant and you suspect that someone has inhaled some food. You know, maybe you're having a good conversation. You're laughing, you're talking, you're eating all at the same time. Someone might have inhaled some food. How do you know how much danger they're in? And the answer here then is that as long as the person can speak or make a vocal sound, this means then that the airway is at least a little bit open, because you can only speak or make a sound using your vocal cords if air is passing out of the vocal cords. So that means that there has to be at least a little bit of an air passage available. But then if the victim can neither breathe nor speak, if you have this problem, if the victim can neither breathe nor speak, then the threat to life, actually, is immediate. They are now in danger of suffocation, and it does not take long to suffocate. And of course, this is why the Heimlich maneuver also known as abdominal thrust. That is why the Heimlich maneuver, therefore, was invented. What is done in the Heimlich maneuver is if you wind up having something lodged here so that it is blocking breathing, then basically pressure is created in the chest, in the lungs, basically pushing air up through the trachea in order to pop out the blockage, you hope. What happens is that someone comes up from behind. You should get trained in the Heimlich maneuver. Everybody should know how to do this. And basically, you come up behind the person and you place a fist more or less above the belly button, and you give them a short, sharp hug, basically in, because you're trying to create pressure here to pop that out. You don't want to go too high. It's hard to compress the sternum, first of all. You're trying to go below the diaphragm in order to pop the diaphragm up. That's what you're working on. The other thing to keep in mind is you've studied the skeleton. You know that on the sternum at the bottom, you have that pointy xiphoid process. You want to avoid breaking that. So you don't go too high. You go a little bit lower in order to basically push into the abdomen, pop the diaphragm upwards in order to create pressure and, we hope, expel the blockage. That's how the Heimlich maneuver works. One problem can be then that, I'm actually going to write this down. So this is compression to the abdomen just below the diaphragm. And this elevates the diaphragm forcefully and it may then generate enough upward pressure to expel the blockage. One problem, not with the Heimlich maneuver, but with the whole matter of tracheal blockage, is that people may be embarrassed about the blockage. That is to say, the victim I'll even write that in. The victim may be embarrassed by the blockage. You're in a social situation. Maybe you're in a nice restaurant. You're eating. You're having a good conversation. Suddenly they can't breathe. They may not want to make a scene. They may think that it will go away. But the problem is, as I have said, that you don't have much time if the blockage is complete. So if you see somebody who is in distress, ask them if they can speak. If they can't speak, then it's probably best to do a Heimlich maneuver relatively quickly. Okay, but getting back to the Heimlich maneuver, the Heimlich maneuver must be done correctly in order to avoid damaging your internal organs. The good news is that the training is easy. I recommend that everybody get this training if they possibly can. So what happens then if you've inhaled something and it's really gotten lodged in there? What if you just can't expel it through a Heimlich maneuver? Well, now a person is in serious trouble, and you better hope that you can get them to a hospital quickly. At this point, things have become far more grave. So, if the blockage remains, then we are in the realm of a tracheostomy. Or a trachea. May be done. And this is definitely one where it needs to be done by professionals. Because a tracheostomy now basically it's a hole cut into your trachea below the larynx so that you completely bypass this upper portion of the respiratory tract and let the air go in there. So this then involves an incision being made through the anterior tracheal wall, as I just showed you. And a tube being inserted. So the hole is made, the tube is inserted, and now the person is basically breathing through that tube. So air then bypasses most of the upper airway altogether. And that is the end of this lecture about these respiratory problems.